All right. So I'm going to be describing some of the 10-year results from a study called the Psychobiology of Suicidal Behavior and Borderline Personality Disorder. This study originated as part of the Mental Health Clinical Research Center for Study of Suicidal Behavior years ago under the direction of Dr. John Mann. And in the year 2001, when Dr. Mann departed Pittsburgh to come back to Columbia, I was able to take this grant independently and turn it into a longitudinal study. So we're now up to our 10-year wave, as Mary would say it. Just some background you're all familiar with. What is the point of studying suicidal behavior in BPD? Well, at intake, 46 to 92% are attempters. Within 2 years of taking these patients into a study, 20 to 25% will reattempt suicide. These people have an average of 3 lifetime attempts at the time they're first seen. And that's a pretty constant number in clinical settings as well as in research settings. The McLean study has shown that the prevalence of suicide attempt does decrease over time, from 20.1% at 4 years of follow-up all the way through 8.2% at 16 years. So it improves over time, less attempts. However, for some attempters, their lethality increases over time. So here, I'm going to show you a couple of examples from past analyses. This was an exploratory analysis using something called trajectory analysis. And what we did was take subjects who had had greater than 3 suicide attempts, some of them 6, 8 attempts, and using trajectory analysis, project the trajectory of their lethality scale scores of each attempt. They clustered into 2 groups. One group we called the high lethality group. It's in green. And the other is a low lethality group. And then we looked at the characteristics of these 2 groups. Another way of looking at this is to look at the high lethality subjects, looking at people who have attempted suicide multiple times. What you see before you are bar graphs of individuals who have had a minimum of 5 suicide attempts, and their lethality scale scores by attempt. Now, this is a small sample, 37 subjects, but you can see that for some of these subjects, by the 3rd attempt, their lethality is increasing. It's increasing to the point it's significantly greater than it was when they tried their first attempt. Again, it's sort of a suggestion that for some subjects, lethality increases over time, even though for the majority, it diminishes and disappears over time. So the Psychobiology of Suicidal Behavior is a longitudinal study. Its intent is to assess the predictive associations of suicide risk factors with attempt behavior, to assess the relationship between suicidal and psychosocial outcomes, and finally, if possible, to characterize subjects at greatest risk. We started with 18 to 45-year-olds, both male and female. They were recruited from inpatient, outpatient, and community sources. This is important because it differentiates our study from Dr. Zanarini's inpatient sample. Ours was well balanced between inpatient, outpatient, and non-patient sources. We did structured multidimensional assessments of risk factors. The risk factors were drawn from the literature. We used a common methodology with the Suicide Center. So we covered as many risk factors as possible, demographic, diagnostic, clinical state. You'll see the lists as we go through the results. And they had systematic follow-ups with repeated assessment the first year at 3 months, 6 months, 1 year, and then thereafter biannually. And the assessment measures, I'm not going to go through all of these in detail, just to point out that the diagnosis of BPD was made on a 2-step process. They had to meet probable or definite BPD using a lifetime time frame on the IPDE, that's the International Personality Disorders Examination. If they got through that, then they had to meet criteria using the diagnostic interview for borderlines. And after it became available, Dr. Zanarini's revised diagnostic interview for borderlines, which we were then forced to do concurrently to keep the statistics straight. So the diagnosis of borderline personality disorder was made essentially by structured interview. The DIB and the DIB-R have a 2-year time frame. So these are patients who are reasonably currently symptomatic. Axis 1 by SCID, and the other risk factors by very standard measures. And again, you can quickly scan them, but I'm not going to recite them all. The statistical methods were fairly straightforward. We used, the most important one was the Cox proportional hazards regression model. The predefined risk factors were the independent variables, and the first interval attempt was the dependent variable. Time to event was from the baseline assessment to the first interval attempt. Now, an attempt, we defined a suicide attempt as clear intent to die with behavior in furtherance of and some medical consequence. The sample that I'm going to show you, everyone has a lethality rating scale score of greater than 2, which means there was some medical damage. For an overdose, for example, a score of 2 would be excessive sedation and seen by a physician. When we talk about high and low lethality in a few minutes, a high lethality is a score of 4 or above, which would mean that you, for an overdose, you were comatose, you were admitted to the hospital. There's one exception in the ways we dealt with the variables. Treatment variables in our study were counted only prior to the first interval attempt. And that is because in our setting, anyone who does a medically significant suicide attempt is going to either be inpatient or they're going to be referred to an outpatient program, and that would confound the statistics. So all the treatment variables you see are prior to a first attempt. Sample characteristics. This sample has 118 subjects, well balanced between inpatient, outpatient, and non-patient sources. The time that we used was the 10-year assessment or the closest assessment that we had to that exceeding 10 years. As a result, we have a mean follow-up in this sample of 14.7 years. The sample, as is typical of borderline studies, predominantly female, Caucasian, no children. The mean age was 44.2 for this particular sample. They were of lower socioeconomic status. And of great importance, there was a big history of childhood sexual abuse. We've reported this multiple times. About 47.6% of our subjects endorsed childhood sexual abuse, physical abuse 41%. So it's a pretty high proportion. Very few had a family history of suicide. A few of them had family histories of attempts. Okay, now I'm going to go through these, highlighting the results that are in red. The red is more for me, so I save time for everyone. We use a Bonferroni correction of 0.001 because of the many comparisons that we made. First of all, I will contrast baseline to 10-year follow-up results. At baseline, 50.8% met criteria, SCID criteria for MDD. At 10-year follow-up, 50% met criteria for MDD. It's very important. It doesn't change. And we'll come back to the clinical significance of that. On the other hand, alcoholism and substance use disorder, which were present in about a third of subjects at baseline, remit quite nicely over a 10-year period, and significantly so. The number of hospital admissions, number of subjects with hospital admissions diminishes, which you'd expect over time. The number of subjects who have outpatient treatment diminishes, as you'd expect over time. Again, baseline versus 10-year follow-up. Aggression diminishes. Hostility. The overall DIB score, so degree of borderline pathology, as expected, diminishes over time. We have one finding that I can't explain, and that is the MMPI psychopathic deviance scale, which picks up antisocial trait. It's significantly increased over time, and I can't explain that yet. So as people become somehow less aggressive, less angry, these folks may become a little bit more antisocial or admit to more antisocial traits. Also importantly, the Barrett impulsiveness scale, which picks up a trait of impulsivity, does not change over time. And that's pretty consistent in the literature. The Barrett is a trait measure. Again, contrasting baseline to 10-year follow-up. The important criteria here, risk factors under socioeconomic outcomes. I highlight the fact that at baseline, it's about 68% of our subjects had personal incomes at the poverty level. That improves dramatically over time. However, the number of, at the end, at 10 years, 41% still have poverty level incomes. The next item, household income, again using federal poverty guidelines. About 60% at baseline are in poverty as far as household. That's a family of 3 living on less than $20,000 a year is the federal definition of poverty. 10 years later, 35%. Again, it's a significant improvement, but think about it. 35% of households with 3 members are living in what the government calls poverty. Government assistance doesn't change much over time, a little increase, but it does not change over time. Global function, important point here is that the global assessment scale on average when we start is 52. 10 years later, we're all the way up to 61. 61 is our definition of poor psychosocial outcome. So it's a significant improvement, but these folks are still doing very poorly. And to express it another way, the percent of people who have poor psychosocial outcome at baseline is 72.6%, but 10 years later, it's 44%. Now, that's a significant improvement, but we're still saying that 44% of these people still meet definition of poor psychosocial outcome at 10 years. Suicidal behavior, there's a decrease in the number of suicide attempts. There's a big decrease in the number of non-suicidal self-injury episodes, or these are actually subjects with these behaviors. Suicidal ideation decreases. So again, this is consistent with what we've said earlier, that suicidality diminishes with time. Now, the predictive analyses. So we began by doing individual regressions on the families of risk factors, the different domains of risk factors, and then ultimately did a common model using those that were significant. So these are the individual significant variables which predict suicide risk. I put in red the ones that meet Bonferroni correction, red and underlined, so you'll understand that they were significant at less than 0.001. And again, the usual characters that you expect. Poor social adjustment scale, that is poor functioning in work and social scales. Poor psychosocial function, comorbid substance use disorder, some depressive mood, hopelessness, a global assessment score that is low, history of childhood sexual abuse, and the scale for suicidal ideation, high scores on suicidal ideation. These are all baseline variables predicting suicide risk. Reasons for living is a scale that, as it suggests, should be protective, and we found that some of the subscales, the overall total scale and item scores and the subscales of the reasons for living scale were protective, significantly so. Among follow-up variables that predicted suicide risk, outpatient treatment in the interval. Now, outpatient treatment in the interval before any attempt. That means these people felt badly enough to seek care before they made a suicide attempt. Psychiatric hospitalization before any attempt. It's in the interval, in the 10-year interval, they sought or they were hospitalized psychiatrically before they committed a suicide attempt. And high lethality status. All are follow-up variables predicting suicide risk. Now, when we put all these together in a single model and choose the best predictors, we find, in some surprises, psychiatric hospitalization in the interval before any attempt is a consistent predictor of suicidal behavior across our multiple studies, 2-year, 4-year, 6-year. I take that as a measure of illness severity. It's nonspecific illness severity. A higher baseline social adjustment scale, which is social functioning and vocational functioning, it's a self-rated measure. A higher score on that indicates poor function. So they had poor function in social and vocational functioning at baseline. They had lower baseline global assessment score, again indicating poor function. So we have 2 rather global measures of social, vocational, and psychosocial functioning at baseline, predicting suicidal behavior in a 10-year interval, that 10-year follow-up. And we have 1 interval criterion, which is illness severity, psychiatric hospitalization. So there's some things missing from that list. There are no Axis 1 diagnoses on that list. There's nothing about borderline personality disorder on that list. Those variables are not predictive of suicidal attempt behavior when you go far enough out. The further out you go in your follow-up, the less important those individual borderline criteria or Axis 1 criteria become. Instead, you're left with global measures of poor social and economic and psychosocial functioning and a crude measure of illness severity. So my conclusions. This, rather than replicate, I should say this confirms important conclusions of the McLean study and the collaborative longitudinal personality disorder study at 10-year follow-up, principally that suicidal behavior and non-suicidal self-injury diminishes markedly over time. Diagnostic and symptom remission are noted in most subjects. However, many, in our study, 44%, have poor psychosocial, vocational, and economic outcomes. The predictors of suicidal behavior include non-specific measures of illness severity in the interval and baseline measures of poor social, vocational, and psychosocial functioning. The attempt characteristics are similar at baseline and in the interval. That is subjective intent, objective planning, method lethality. So the threat of lethality persists for some subjects. They do the same things or maybe even, well, not statistically significantly, but we know some of them increase their lethality. But these predictors, these three groupings, that is psychosocial, social and vocational, and illness severity, happen to be the same predictors that we found which were characteristic of high lethality attempters in our exploratory trajectory analysis. So we're looking at a group of risk factors which predict higher lethality over time. The attempts are, as I said earlier, attempts are not predicted by specific BPD or other personality traits, no Axis 1 comorbidities, though they may contribute to illness severity. Depression persists. Whether this is true MDD or negative affectivity or characterologic depression, it is refractory and it contributes to poor psychosocial outcome, especially vocational effort. Psychosocial outcome was found not to be related to attempt behavior. Now, there's one of the clinicians I presented this to thought this was good news, and it is, because it means a history of suicidal attempts does not preclude a good outcome. And we all know this clinically. We all have had patients who have attempted suicide earlier in their careers and yet are able to pull themselves together and achieve a successful outcome. On the other hand, psychosocial outcome was not related to any history of treatment. Now, this was not a treatment study, so I can't say anything about efficacy. But treatment itself did not predict psychosocial outcome. Finally, current treatments do not address the educational and vocational deficits which contribute to poor outcomes and suicide in the long term. And clearly, a rehabilitation model is needed. And Dr. Paul Links, back in 1993, proposed a fairly comprehensive model for this, but to the best of my knowledge, no one has taken it up or systematized it or operationalized it. So there's room for work in the rehabilitation efforts for borderline patients. Thank you. Questions? Yeah, any questions? Yeah.
Great talk, thank you. And it's really true that there's a study, because especially because the patients have been forced
Right.
Yeah, and finding this consistent things across the different studies really amazing and great. But I just so you were talking about the patients, one of the predictors of suicide risk, or suicide attempt, was the interval they had been considered hospital, right?
Correct.
So if you were talking about it as a marker of illness severity, and I was wondering if you had other markers of illness severity in that interval that you could look at, instead of looking at, just static predictors, looking at time-varying predictors of this ratio of the likelihood.
Well, there were variables which were dropped out of the model statistically in favor of psychiatric hospitalization.
The illness severity,
Yeah, the way I interpret that, it's nonspecific, but the contributors to that must include Axis 1, like major depression, suicidal ideation, hopelessness, some of the other factors which on individual models were statistically significant must contribute in some way to overall illness severity. But when you put them all together in a statistical model, they drop out in favor of the strongest, which was this psychiatric. And ironically, this is the same variable that's shown, it came up in our 2-year analysis, our 4. It's nonspecific, but somehow people being hospitalized before they do any attempt behavior strongly predicts future attempts.
And I guess, regardless of the fact that it just might be marker of illness severity, it really strikes me that for psychiatric hospitalization is not helping to prevent suicide behavior and suicide attempt. And I think that's a really important finding that I actually, have you published that? Is that what you just showed us? Is that out?
This paper is in my briefcase. It's still being, in fact, I'm collecting comments, so yeah, your issues will be represented. It'll be submitted within a week or two. But yeah, and my findings are somewhat, they certainly confirm what Dr. Zanarini has done, but our population is very different. There was a poster presentation by someone who's working with you yesterday, and that showed the comorbidity in your inpatient sample. And almost across the board, the comorbidities are higher. Depression is higher, substance use is higher, PTSD is higher. You worked with them, and your patients were all inpatients, and they were much sicker than our subjects. And an indirect proof of that is that our suicide rate. We now have over 360 subjects. We have 3 people whom I consider suicides, 1 by hanging and 2 by overdose. And that's it. So that's less than 1%. Again, unfortunately, I know some of these people, and I don't have the kind of closeness to them that Mary had, but I was clinician for several of them, and they've had many high lethality attempts, and just for medical circumstances, well, the hanging was clear, but the overdoses could have been saved had they been found in time. But only 3, that's less than 1% of our population. But again, our population, 1/3 inpatient, 1/3 outpatient, 1/3 non-patient, much less ill than Mary's population. One other follow-up, among the 13 deaths that we have, over half are what I refer to as lifestyle related. And this is something Dr. Temis might want to consider looking at your death numbers. Lifestyle related deaths include consequences, chronic consequences of substance use, for example. We have a number of people who died by cirrhosis, and those are written up as natural deaths. Their autopsies don't say anything about suicide. So we have cirrhosis, we have alcoholic pancreatitis, which are considered natural causes. But they're lifestyle-related deaths. They're not normal, and they come very early in life. So there should be a separate category for lifestyle-related deaths. Other questions? Yes, ma'am.
So I thought it was interesting that you characterized the hospitalization as psychiatric illness, because it seems like it could capture an intersection or an interaction between illness severity and kind of lack of resources in some way, which might be why it's a better predictor than things that simply capture psychiatric illness. Since, I mean, at least in the inpatient units that I've worked on, the people who come in the most are the people who aren't getting care elsewhere in the community very effectively. Those people are the frequent flyers of the psychiatric units. And so I wonder if the people who are coming in more often, if that also captures lack of available resources in their community, and it's capturing some sort of SES kind of component as well as the illness, and that's why it's such a good predictor.
Well, that's an excellent point. My clinical setting, Western Psychiatric Institute and Clinic, treats a large indigent population. It's now, again, with all due respect to McLean, even with McLean in the modern era, we're still probably treating a more indigent population. We're a public hospital, basically. And as you suggest, some of our frequent flyers are there because they can't afford therapists, because they neglect their own care, and they are neglected. And that's reflected in the low socioeconomic status, the poverty levels that we have in our population, which were significant predictors of risk, personal income poverty, family, household poverty. Again, it may be a reflection of the lack of resources of our population. But it's a very good point.